All right, hello. Thank you for the opportunity to speak with you about cancer and HIV. My name is Warren Phipps, and I'm an infectious disease physician at the University of Washington and the Fred Hutch Cancer Center in Seattle, Washington. Although I live and work primarily in Uganda, where I serve as the medical director for our longstanding collaboration between the Uganda Cancer Institute and the Fred Hutch Cancer Center, which is focused on supporting research, care, and training related to HIV-associated cancers and other virally mediated malignancies. So for today, I was planning to touch on several aspects related to HIV-associated malignancies. The first being, what is the various cancer risk in people living with HIV? Then looking at the global burden and distribution of HIV-associated malignancies, talking about the role of HIV in cancer pathogenesis, and then ending with some discussion about cancer treatment and prevention. So let's talk about the role of HIV in cancer. Really, from the very beginning of the recognition of the HIV epidemic, the link with cancer was clear. And in fact, in the very first reports heralding the HIV epidemic, it was really through the observation of Kaposi sarcoma in young MSM in New York and San Francisco, which were the initial reports. So very early on, it was clear the link between cancer and HIV was present. And early on, there were 3 AIDS-defining malignancies that seemed to be occurring in people living with HIV at a higher frequency and more aggressive. And these included Kaposi sarcoma, various non-Hodgkin lymphomas, as well as cervical cancer. And interestingly, and we'll get back to this, all of these ultimately ended up having a viral etiology associated with them, with HHV8 associated with Kaposi sarcoma, EBV with many NHLs, and human papillomavirus and cervical cancer. So as the HIV epidemic evolved and changed over time, so did our understanding of the link between cancers and HIV, particularly as antiretroviral therapy was effectively rolled out in large populations. And as an example, here's a large meta-analysis of patients living with HIV in the US, led by Meredith Shields at the US NCI. And what they looked at was changes in incident cancers between 1991 and 2005. And this is showing the cancers on the x-axis, on the y-axis, and the time periods along the x-axis. And the green bars show those 3 AIDS-defining malignancies, KS, lymphoma, and cervical cancer, and the blue are all other cancers. And you can see over time that the green bars certainly decrease. The number of the AIDS-defining malignancies overall is fewer, but these blue bars, the proportion of cancers of non-AIDS-defining definitions, was increasing with time. And so what's really kind of interesting is this inflection point around 1995, when effective ART was introduced more widely in the US. You can see that that seems to be a point at which there is a change in the types of cancers being seen. So it's important that also that there is still a persistent burden of disease despite the rollout of ART. So while the distribution of cancers changed, certainly the burden of cancer was still very clear, even early on in the post-ART era. So there's further evaluation of the risk of cancer in people living with HIV was assessed in a really terrific meta-analysis of cancer incidence that included 7 studies of adults with HIV. And it followed a range of follow-up periods, but from 1980 to 2003, so a wide period of time. And these were studies that were primarily conducted in research-rich settings in the US, the UK, Switzerland, Italy, and Australia, and included almost 500,000 people. And again, this study found a very strong association with the original AIDS-defining cancers, with Kaposi sarcoma in particular being strongly associated with an over 3,000 increased risk of KS among those with HIV infection. Also a very high SIR for NHL, interestingly, not as high, but still elevated for cervical cancer. But in addition to the ADMs, this team also identified several other cancers which were strongly associated with HIV. And these are cancers that you are likely to see in your practice. And interestingly, many of these, again, are infection related. So some of the high non-AIDS defining cancers identified included anal cancer with almost an SIR of 30, also higher rates of vulvar, penile, liver, stomach, and respiratory cancers. Overall, any NACD was increased almost 2 times among people living with HIV compared to the general population. So now looking again at Meredith Shields and Eric Engels from the US NCI, they've now tried to look at where do we think the trends will be going. And again, this is looking in the US, and they have something called the HIV/AIDS Cancer Match Study, and they use that to project through mathematical modeling what are the likely cancers of people living with HIV as the population ages. And so they looked at changes in those who would be 65 or older from 2010, which they estimated at 8.5% of the total population, to close to 21% by 2030 of people being over 65 living with HIV in the US. And I think the important point is that when they looked over time, there was again a projection for a change in the types of cancers that we are likely to see, with some of the more common AIDS-defining malignancies, lymphomas, and KS in the early part of the cohort in 2010, shifting to have a higher percentage of prostate and lung cancer dominating the field. And again, this is most likely due to aging that is shifting this burden. And so I think the important point is that since the beginning of the HIV epidemic, there have been cancers strongly associated with HIV infection. However, we need to continue to monitor the types of cancers that our patients are getting, which is very dependent on the population and the context of that population. And so to that, it's important that we also look at what is happening outside of the US and other high-income countries. And so this is a paper led by Valeria Fink from Argentina that looked at cancers among people living with HIV in Latin America. And as you can see here, they considered patients from Argentina, Brazil, Chile, Honduras, Mexico, and Peru. And combining those, they still saw very high rates of AIDS-defining cancers in their population. So nearly 3/4 of the identified cancers were AIDS-defining cancers, compared with roughly 1/4 of non-AIDS-defining cancers. And so again, this group reported high rates of Kaposi sarcoma and lymphoma, but they also were seeing fairly high rates of Hodgkin lymphoma, as well as skin cancers in their population. Looking at sub-Saharan Africa, the registries in Africa unfortunately don't routinely collect HIV status as part of their reporting structure, but to get an idea of how HIV might be driving the cancer burden, I'm showing you now estimated incidence of cancers in East Africa that's been developed through Globocan, which is supported by the International Agency for Research on Cancer and WHO. And so looking at overall population cancers, cervical cancer is by far the highest, both in terms of incidence and mortality. But you can also see that other cancers associated with HIV infection, including capillary sarcoma, NHL, perhaps even liver cancer, are also very high. So it suggests that in cancers that have, or sorry, in countries that have a high prevalence of HIV infection in the population, we were also seeing higher rates of many cancers associated with HIV infection in those populations. And looking at this at an institutional level, I mentioned that I work at the Uganda Cancer Institute in Kampala, Uganda. And certainly from our experience, we have a very high burden of HIV in our population of cancer patients. And this is a study where we surveyed the cancer scene at the UCI over the first quarter of 2015. And we found that nearly 1/3 of all cancers, or patients with cancers who were diagnosed that time, had HIV co-infection. Again, the distribution of HIV infected versus HIV uninfected patients varied by cancer, but overall, a very high burden of cancer in our population of people living with HIV. So let's talk now about what are the factors that may be increasing the risk of cancer in the setting of HIV infection. And there's actually certainly several, and the story, like many of our stories in medicine, it's complex. But some factors that most likely are contributing include immunosuppression, the role of HIV replication in the HIV virus itself, co-infection with oncogenic viruses, and then importantly, how this may all be modified by antiretroviral therapy. So, you know, a lot of data has come out recently about our understanding of the immune system and its role in cancer. And this idea that the immune system plays a role in immune surveillance, where it may remove cancerous cells early on in the potential pathogenesis. And there's an idea of elimination, equilibrium, and escape, that if your immune system is intact, it's able to eliminate or at least maintain a small burden of cancer cells. But if those are able to escape immune surveillance, that's when cancer may develop. We certainly see a higher incidence of cancer in many organ transplant recipients, which is also suggesting that immunosuppression related to transplant could play a role in fostering cancer development. And finally, the converse to that is in many transplant cases who have developed cancer, reducing immunosuppression may lead to regression of that cancer. So, for instance, capillary sarcoma has been observed frequently in kidney transplants, but by reducing the levels of immunosuppression, KS can resolve in that context. And so I think this is a proof of principle of the importance of immune status in cancer development, particularly potentially for many of our HIV-associated cancers. Another way of thinking about immunosuppression is CD4 count. And these are graphs from a study of US HIV registries that looked at over 300,000 adults with HIV between 1990 and 2002. And this was showing in these graphs the incidence of the AIDS-defining malignancies and their association with CD4 count at the time of diagnosis. And so you can see that on the y-axis is the incidence of those cancers, and along the x-axis is the CD4 count, with the lowest CD4 counts on the left side and the higher CD4 counts as you move right along the x-axis. And there's a general trend for capillary sarcoma, as well as the non-Hodgkin's lymphomas, for increasing incidence with lower CD4 counts. suggesting that these cancers are very much indeed associated with CD4 levels. Interestingly, cervical cancer on the right upper panel does not seem to be as associated with CD4. So I think it tells us, at least in terms of CD4 counts, clearly immunosuppression and T cell repertoire is not the whole story behind cancer risk. This is now looking at the article by Grulich et al., which was the large meta-analysis of 7 studies that I showed you before. And going back to the idea of transplant, they compared cancer risk in HIV, or people living with HIV, to those with transplant. And they did find that in many cases, the incidence of cancer was higher among HIV patients than those who had received a transplant. But this was also very dependent on the type of cancer. So for instance, you can see here, this first line is looking at Hodgkin lymphoma. The SIR is higher, so increased rate or risk of developing that cancer among our HIV AIDS patients compared to transplant patients. Similarly, you can look at Kaposi sarcoma about midway through this graph and see a much higher rate of Kaposi sarcoma in people living with HIV compared to those who have received a transplant. However, those differences are not quite as strong when you look at liver or stomach cancers. So again, immunosuppression is part of the story, but there's probably another factor going on here. So what could that be? There are data to suggest that HIV infection itself may contribute to the risk of cancer. And this could be through a direct effect or possibly an indirect effect. And so here I'm showing you a study from France from 2009, where they followed over 4,000 patients over an 8-year period. Again, these were the late 90s to early 2000s. And they looked at what were the factors associated with a new cancer diagnosis. And they again did find that CD4 count was important for many of the cancers, and there was an association with a higher incidence of the AIDS-defining malignancies with lower CD4 count. But interestingly, they found that plasma HIV viral levels were independently associated with the risk of developing cancer. And so that is suggestive of potentially a direct role of HIV in contributing to cancer risk. So what could the mechanisms be by which HIV may contribute to tumorigenesis? And there's several that are postulated. One is a concept called viral synergy, where HIV may basically increase the replication or potentiate other viruses that are known to cause cancer, such as when human herpes virus 8 or Kaposi sarcoma associated herpes virus has been found to be able to utilize the HIV TAP protein to increase its own replication rates. HIV may also promote a pro-inflammatory milieu in the environment or the tumor microenvironment, and this inflammation may contribute to the development of cancer. And there may be some ways in which HIV affects cellular processes by activating either oncogenes in cells, inhibiting tumor suppressor genes, and increasing data suggesting that HIV can integrate into some cancer-promoting genes as well. So, some data for HIV having both an indirect and a direct effect on development of cancer. But I do want to also talk about other viral co-infections besides HIV, which likely contribute to the risk and distributions of cancers. And it's interesting that probably about 1/4 of cancer cases worldwide are caused by infections, with another quarter roughly caused by having a genetic factor that's been identified, another quarter with an environmental factor, perhaps like tobacco as a cause, and then again another quarter roughly that we don't really yet have a clear etiology for that cancer. But there's, I think, the infection-related cancers are important, particularly in our population of people living with HIV, because it may allow itself or lend itself to the use of vaccines or other treatments to prevent and treat these cancers. And so here's a list of some of the known oncogenic infections. So as we've mentioned, HPV is related to cervical, anogenital, and oral cancers. EBV having a strong association with nasopharyngeal cancer as well as lymphomas. Human herpes virus 8 as a cause of Kaposi sarcoma. Hepatitis B and C causing liver disease, as well as others on the list. I do want to highlight the importance of Helicobacter pylori in stomach cancer, which is a very high burden of disease, particularly in Asia, and schistosomiasis as a cause of bladder cancer. Another way of looking at the important role of co-infections is that there's an estimate that roughly 20% of all cancers are related to just 5 infections, and that would be EBV, Helicobacter pylori, hepatitis B and C, and HPV. So focusing on these really is important and has the potential for us to have a big impact on global cancer incidence. And why is this important, particularly when we are thinking about our people living with HIV across the globe, is that we are able to see through our cancer registries that infection-related cancers vary differently by geographic region. And so what this figure is showing, again, through our IARC GloboCan data, is that nearly 40% of all cancers reported in sub-Saharan Africa have a known infection-related cause. And the dark blue is specifically HPV, HBV, or C, and Helicobacter pylori. And you can then go and see, for instance, as you go down this graph, Latin America also has nearly a quarter of cancers associated with an infection compared to Europe and North America, which is closer to 5%. And where I am, thinking of Uganda, we can see that 6 of the top 10 cancers observed in our population have a known infectious cause. And again, I think this is important to recognize that when we think about our HIV infections in people living with HIV, we need to really contextualize where they are and what cancers they may be at highest risk for. So the other factor that I wanted to discuss related to the role of HIV in cancer development is really now thinking about HIV treatment and how it may impact the development of cancer. And there was a very important study that was published in 2015 from the New England Journal of Medicine called the Insight START study that was evaluating the benefits of starting early ART. And this is a study of nearly 5,000 patients with HIV infection who were assigned to start ART immediately on diagnosis or deferring the start of ART until their CD4 count was less than 350 counts. And they followed them up for a median of 3 years. And the important point is that the hazard, they found that cancer incidence was significantly decreased for many cancers through early ART initiation. The hazard ratio for Kaposi sarcoma was 0.09, so almost 90% decreased risk of KS for those in the immediate initiation group. And looking for any cancer combining AIDS and non-defining cancers, the HR was 0.36, so over 60% decreased risk of developing cancer in those who immediately started ART. We've done some work in sub-Saharan Africa. This is Innocent Umtiaba, who's led this study, looking at least in Uganda over the rollout of ART in the population. And he's also found decreases in KS and non-Hodgkin's lymphoma. However, a lesser effect on cervical cancer as ART has been rolled out. Similar work has been conducted in Botswana. And again, they are finding that some cancers, particularly KS, do seem to be decreasing as ART is rolled out more broadly, but other cancers are also increasing, including anogenital cancers. So really, where is this taking us? Recognizing that there is such an important association and increased risk of cancer in people living with HIV, what can we do to screen and better prevent the development of these cancers? And so here's an example of guidelines through the European AIDS Clinical Society that do have clear recommendations for screening for people living with HIV, and this includes mammography for women beginning at age 50, cervical pap smear or cytology for women with HIV infection who are over 21 years, both a rectal exam and anoscopy, and let me come back to that in a moment, as well as a recommendation for PSA screening in men over 50, although this is somewhat controversial about the role of PSA, but the European AIDS Society or Clinical Society does recommend that. The issue of anoscopy was somewhat controversial until recently. A new study that was just published earlier this year called the Anchor Study, which was looking at anal cancer prevention in people living with HIV. And this was a randomized controlled trial to determine whether treating anal high-grade squamous intraepithelial lesions, or HSIL, is a safe and effective strategy for reducing progression to anal cancer. And this was a study of nearly 11,000 people over age 35 living with HIV who were screened for HSIL. And of these, about 4,500 people who were diagnosed with HSIL were enrolled to the study and assigned to either receive treatment with electrocautery or to receive just active monitoring with no treatment. And the study ultimately found, after just 2 years of follow-up, that treating HSIL with electrocautery led to a 57% reduction in the risk of anal cancer diagnosis. And the study was actually stopped early because of the significance of these findings. So this is now suggesting a much clearer role for anoscopy and screening for HSIL now that there is a potential intervention, which of course will need to be implemented, and that there's many steps ahead to make this more feasible at many centers across the world. So I think, just summarizing some of the key points here were that ART certainly has a role in impacting our cancer burden. And we've seen that it will likely change the distribution of cancers, increasing the more, quote, non-AIDS defining cancers, but that the overall cancer burden will likely remain high in our population of people living with HIV. And we need local research and strong cancer registries to understand how the co-epidemics evolve locally. There's a need and opportunity for screening and early detection in high-risk populations. And perhaps we can better utilize HIV care infrastructures, particularly in other LMIC low and middle income countries, to better perform screening in our high-risk HIV populations. And then thinking about prevention. Early ART as a cancer prevention strategy is critical, but also continuing to focus on HIV prevention as a cancer prevention strategy as well. I do want to point out that there are significant treatment options for all of the cancers that we've discussed that are highly associated with HIV infection. And for the purpose of this talk, did not think I would be able to give all of those recommendations, but instead I wanted to highlight where guidelines for treatment of many of the HIV-associated cancers are freely available. And there is an organization called the National Comprehensive Cancer Network, or NCCN, and they have developed what are called harmonized guidelines that are resource stratified guidelines that allow you to associate recommendations with resources that may be available to you in your setting. So this is an example of the title page for sarcoma, and within this, there's details of ways to stage, treat, and monitor these cancers. And again, depending on what resources are available in your setting, you can choose which approaches may be most optimal for your patient. Similar guidelines exist for all of the cancers that are highly associated with HIV, including lymphomas, cervical cancer, anal cancer, and others. So I would encourage you to log into nccn.org if you want to find out more about treatment options for your patients. This is freely available after you sign up. So with that, I just wanted to say, thank you. Again, I think what I'd like to have you take away from our talk today is that HIV-infected individuals have an increased risk of a wide range of cancers, including both AIDS-defining and non-AIDS-defining. The factors that contribute to pathogenesis include the direct effects of HIV infection, immunosuppression, co-infection with oncogenic viruses, as well as how this is modulated by antiretroviral therapy. Widespread ART has led to changes in the epidemiology of cancers in people living with HIV, and integrating screening strategies into HIV care will likely be a critical strategy for preventing cancers or detecting them early. So with that, thank you very much. I appreciate your time and wish you the best throughout the course. Thank you.